Good morning, Mark. It's great to see you again. I think SIU had a great idea to mount this interview with you. I think you are a legend. Everybody knows you. You had you wrote a lot of papers, more than 500. And so you are an excellence in the oncological field also. It's a great opportunity for us and for SIU to know something a little bit special about you. Like, tell me, what's the reason you decide for urology? First question.
Well, when I was in medical, first of all, Maurizio, thank you for the opportunity. It's good to be with you. I want to give you a big hug, but unfortunately, over the video, we can't do it today, but hopefully soon in Italy or here in Miami. So I was very fortunate. In medical school, we had to do a thesis. It was required to graduate. You had to do research. And I did research in neurosurgery. So it taught me to do surgery, that I could do it. And because I would never have done research, I would have gone to be a regular doctor. And my father was a physician, OBGYN. So I wanted to be a doctor. But I saw I could do surgery and I could do research. And then the most important step, of course, then was I went to the National Cancer Institute. And I liked urology from the very beginning. And I made a decision when I went to the National Cancer Institute to go into the surgery branch. So that was a very big moment in my life.
Okay. And then you start urology, and we know everything. I mean, I know almost everything about you, but one of the interesting things I would like to know is why you decide for oncology and bladder cancer especially.
Well, when I went to the NCI, I decided something in surgery, but I already in Cleveland had met the chief of urology, and when I was my intern. So I went to the NCI after 2 years of general surgery. So I was already exposed to urology. And they were very nice people. You had your own field. And so I said, okay, I like urology, surgery, medicine. It's a good field. When I went to the NCI, God must have come to me because I had to do a research project. I had no idea what was I going to do. And I found this article where you can give mice a carcinogen and they all got bladder cancer. I said, wow, because bladder cancer at that time, we're talking about the early 1970s, we could do surgery and that's about it. We didn't even do good TURs, as you remember, way back then. Yeah. So I said, there was no chemotherapy, only 5-fluorouracil. So I said, okay, I can make a model. I have 500, 1,000 mice running around developing bladder cancer. What can I do? So that's how I began. Fortunately, again, a stroke from the heaven, whatever you say, it was fate.
Okay.
And then I was very lucky with these mice. What do you do? And there was a drug called cisplatin. Never had a human being have it at that point. And they gave it to me and says, okay, if your mice will not die from it, they try to use it. And it worked. Cisplatin worked against this urothelial carcinoma.
And I remember that the dose was also very high, was 1 gram. They could tolerate a big high dose. Really?
No, you had to be very careful because in humans, they thought they would all die because their kidneys would die. So it had to be discovered. So I was very careful. But at any rate, we got a right dose. The mice could survive. The tumors were much smaller, and that the rest is history with cisplatin.
Okay, thank you. And now, let me ask you this question. You published more than 500 articles in peer review paper journals, and you did a lot of research. Just in few minutes, tell me what you think were the most important and most leading article or research you've done.
Well, the first thing, Maurizio, as you very well know, because you spent time with me both in Memphis, Tennessee, so we can go visit the home of Elvis. And then you came to Miami so you could play your football while I was working.
Yeah. I remember I played football also in Memphis. It was with the dental student. You remember?
Yeah, it wasn't fair because you were an Italian professional player coming to play with these kids, you know.
But it was fun. We had a
Naturally,
lot of fun.
when you win, it's fun, right?
Yeah. Yeah.
So
Okay.
when I left the NCI, I took my mice with me. So the first project I did was to say, why do people get bladder tumor recurrences? Maybe implantation is a factor. So during my residency, I showed that implantation on the cauterized surface of the mouse bladder, the tumors would live and grow in the bladder. If you only cauterize, they would not. So I said, hey, maybe we should get an intravesical chemotherapy after a TURBT. So I think that was an important to show that implantation occurred, and then continued with the story about mitomycin C. And eventually, 20 years later, that became a guideline, post-op intravesical chemotherapy. One of the reasons it works may be because of implantation. The second, I would say, area I thought was important, continuing the cisplatinum. When I went for my first academic jobs in Memphis, none of the medical oncologists knew about cisplatinum. It had just been approved. And I talked to Alan Yagoda at Memorial, Cora Sternberg, of course. I would communicate, Howard Scher. So I'm a urologist, just became a urologic oncologist in Memphis, one of the only in the area, and I gave my own chemotherapy. And I saw that it worked in humans just like it did in the mouse. And I began publishing many articles about the use of cisplatinum, and even said at that time, this is now in the 1980s, that it should be used before radical cystectomy for neoadjuvant. And later, of course, that became a guideline. In addition, again, using that mouse model, I incorporated cisplatinum plus radiation. I said, maybe cisplatinum can help with radiation. Use that in the animal model and then in my patients, and eventually randomized trial with George Prout and the National Bladder Group, and it showed that radiation and platinum should be used. So I took what I learned from the animal model to the human, and again, as you know very well, even today, that's a guideline. Give chemotherapy along with radiation for bladder preservation. Probably the next step, in 1985, I was one of the very first in the United States to have a flexible cystoscope in my hand. People from Olympus gave it to me.
I remember.
Remember that, right?
Yeah.
And people said, that's a terrible idea. You can see nothing in the bladder. You're looking through the eyepiece, you cannot see anything. I said, yeah, but for the patient, it's like amazing, because everyone was using that rigid cystoscope. Even in the office, they were killing their patients. It wasn't the doctor getting the cystoscope. And when I
killing is too much.
Exactly. So when I presented that at the AUA, the urologist says, you are crazy. It will not work. When I went to Miami, this is 1991, they were still using the rigid cystoscope in the office. So I said, look, the flexible cystoscope is the way to go. If your rigid scopes break, as the chairman, I will not fix them again. So,
I tell you something, Mark. As soon as I came back from Miami, and when I saw the flexible cystoscope, I started doing it in my office. Also, wow. I was one of the first in Italy because I saw you. Yeah, it was great.
Good for you. I'm glad to hear that. I didn't know that. Maybe one of the next, I would say, important things was, again, a stroke from God. I was already doing, like you, transrectal ultrasound procedures. And in the year 2000, John Obeck from Turkey was with me. And I said, John, we are doing no anesthesia for the patients. You go to a dentist and they right away, they numb your mouth before they give you the xylocaine. And then they would not trim your cavity. They fix your tooth without local. We are doing no local anesthesia. So he said, you know, there was a little, some young man in Turkey used a needle, they put it in alongside the tract and did anesthesia. So I said, wow, let's do that. So we got the long spinal needle. And in 2000, I published 50 patients in the Journal of Urology to periprostatic nerve block. And interestingly enough, when I presented as a poster at the AUA, some people from a university I won't tell you about, a very famous, says it doesn't work. I said, it does work. 2 years later, he came to me and said, you know, Soloway, you were correct. And then, of course, now you would never have a prostate ultrasound in the office without anesthesia. Probably,
okay.
Yeah, go ahead.
No. Go ahead. If you have something else, you did many things. I mean, many research.
Yeah, I would say the next area I thought was important had to do with the biology of prostate and bladder cancer. So in 1985 already, because we had looked at radical cystectomy specimens and found that 35% of the patients had prostate cancer, I became convinced that, like in England, you don't have to treat everybody. So in 85, I wrote the first paper, particularly with older patients, that you don't have to treat every prostate cancer. And eventually got very involved with active surveillance with prostate cancer. And we wrote many papers on active surveillance. And then in 2003, I also thought the same for low-grade TA bladder tumors. And you and I in Miami and in Memphis, we talked about this all the time.
That's interesting. Yeah, very interesting.
Animal.
Yeah.
So in 2003 was the very first article that you don't have to treat every patient you see a little bladder tumor. Then you can do active surveillance or you can do office cautery. And actually your Italian group there has had the biggest series subsequently on active surveillance. Yeah. And I thought that the fact that you don't have to aggressively treat every cancer, particularly prostate and bladder. Okay. And then finally, I think I have to mention Gaetano Ciancio, who you know.
Yeah.
So this is a message I have for the urologist. You don't have to be a superstar. When I saw that Gaetano now trained in liver and kidney transplant, and he was a resident with me when I first came to Miami. So I knew Gaetano as a resident, and then I watched him as a fellow in the transplant program and became a transplant surgeon. I said, Gaetano, we are doing with these big retroperitoneal masses, IVC thrombus. I know from my time in Memphis that the liver transplant guys, they move the liver anywhere around, and it makes the exposure much more nice and much more safe for the patient. And so Gaetano and I worked together and started writing all these articles about transplant techniques, particularly liver or spleen mobilization, for the benefit of the patients with large retroperitoneal tumors. So I had to listen to him speak in Italian, swearing in Italian.
Which was good, I mean, which was good. So but you don't speak any Italian very well. I mean, it's grazie, ciao, and that's it.
That's it, you got it. And
okay, but now let me go to a funny thing. I mean, let me know some stories during your meetings, your traveling, with your residents and so on. Something funny. What happened to you, for instance?
Well, I guess I was thinking there are two things probably. First of all, when I was in Memphis, I was told, of course, Elvis Presley was alive, and his medical doctor called me one evening and said, Mark, this is true. I swear to God on the Bible next to me. Elvis has phimosis and he needs a circumcision. So I said, okay, I'm ready whenever you tell me. He said, no one can know. In the middle of the night, Elvis will come. You figure out where you will do it. So in 1977, I was in Baptist Hospital in Memphis, and the word came around, Elvis died. I said, oh my God. And I went to talk to my secretary, and I told her, you would have thought I said that her father had died. She started crying. I was crying too, because if I did a circumcision on Elvis, I could have retired. All the women would have said, let me touch your hand, Mark. Let me touch your hand. So unfortunately, that was a little bit of a funny but sad story.
Yeah, yeah.
And the second story is when you left me in Florence. So when you and I went to dinner, and I had my car and I had my children, my little children with me, and you said, okay, after dinner, my hotel was somewhere, I don't know, I was going to follow you, and I came outside, and there's no Maurizio. No Maurizio.
I must say that Mark was in Florence because of a meeting. Of course, he was invited, and I invited him. And it happened that I was looking for Mark, and I couldn't find him. So go ahead.
How I ever got to my hotel, I have no idea. I speak no Italian. I did not know where I was, and I made it. I'm still alive, so thank God also for that one.
Everybody is fine, so it's funny. Okay, and I think we had to conclude this this interview saying that we are working together in an international group on bladder cancer. And can you tell me something about this group? I think it's a good group in bladder cancer, and I think we publish many papers, many articles. So we try to be update. What do you think?
No, I think it's a good idea. We need guidelines. I think a very important thing is prostate cancer. So many people have that in their focus. And bladder cancer, in most of our career until more recently, that was like on the back burner. No famous people came forward, said they had bladder cancer. Even today, the cigarette smokers don't know they're at risk for bladder cancer. And so I think having an international group that's putting more and more focus on new developments, new guidelines, what is correct, I think it's a good idea. Speaking about TA being not important to do radical surgery, to do BCG, etc., to overtreat them, and then to find better ways to treat locally advanced bladder cancer. And then, of course, in the middle, what to do with the BCG failures. So all of these, I think our group has contributed something. And of course, you have put a big emphasis on the importance of the TURBT. I'm very proud of you for that, because that is the basis, that's the foundation for all decision making. And if you can't begin with giving the pathologist a good material, an adequate material, then you're going to make a judgment mistake in the way to treat the patient.
Yeah, I like to thank you because I still think that a good TUR, a good first TUR is a basic of everything in bladder cancer.
And it's a very much underappreciated operation. The young guys don't really learn this from the best person and the professor on an everyday basis. People say, oh, that's a simple little procedure. The first year resident, the first year trainee, will go and do the TURBT. But some of these cases can be really a challenge, as you know.
Yeah. So I think we're gonna finish, and I would like to thank you for this interview, for being here with me for a little, and I hope to see you soon somewhere, probably in Italy, maybe.
Everybody in the States wants to be in Italy, and let me tell you, you have a wonderful life there, I know.
Yeah. Now we are almost COVID-free, not COVID-free, but you know the number of that are reduced very much, and so we are almost out.
Beautiful. Okay. Maurizio, great. Thank you, sir.
Ciao, stai bene. I thank you very much again.
Okay.
Ciao, Mark.
My pleasure. Thank you.